From the University of Toronto's Leslie Dent Faculty of Pharmacy, this is the I'm Pharmacy podcast. I'm Mina Tadros. When I was a pharmacy student, doing some of my first rotations in hospitals and on different units, one thing that struck me was the power of evidence. People would be able to recite, mention, pull up any clinical trial to support some of the statements and uses of things that they wanted to see done. Evidence for much of what we do in healthcare is cited as scripture. Studies aim to shape how best to care for patients. People cite papers as a means to improve or change the way we care for our patients. And many times when these trials are done, they are groundbreaking, and the hope is that they have huge impact. Combine this power of evidence with the fact that the evidence being produced is astronomical. We produce lots of science. I mean lots. There's an estimated 125,000 medical or clinical studies published per month in 2021. That means that there's over 1 million different papers with lots of different evidence in different spaces being produced a year. And yet with all of this knowledge, we seem to see a plateau in people's health and health outcomes. We don't see the health systems working well. And we've dedicated this whole season to just these problems, many of which are studied extensively. It's not a lack of evidence. So how can this be? How can it be that despite the availability of high quality evidence, amazing science, and proven effective interventions, there's a delay or a failure to get this knowledge into practice? Let's take a simple example. This is going to seem shocking for some of our listeners, but in many places in healthcare, hand hygiene is still a problem. A few years ago, a group of researchers conducted a systematic review of interventions to improve hand hygiene. They found there was many studies, ways to improve it, feedback, posters, education, you name it. And they learned that there's many strategies that can be combined, and they wanted to implement them. They wanted to try to improve the hand hygiene in their organization. So they tried to implement them. But no matter what they tried, they found that many of these strategies in this large hospital institution that they were in faced several challenges. Nothing seemed to change. But why? This was baffling to many. And after they took a deeper dive, they found that some of the staff were resistant to these change of their habits. Some of the managers were reluctant to allocate resources, the time, the training, the monitoring. It was something being added on to an already busy schedule. As a result, the implementation of something that seems like a no-brainer was not successful. This story shows that evidence alone is not enough to change practice, and you can't depend on a single study or hundreds of studies to influence it. We need to understand the context and the factors that influence behavior change. And basically, as I read through preparing for this episode, it seems like there's two problems. One, there's lots of evidence, and some of it doesn't always agree with each other. And the second, we have systems and human beings. In response to this type of problem, there seems to be two types of solutions emerging in science. The first is the evidence problem itself. And to solve this, people have come up with ways to combine evidence to meta-analyze things and bring it all together. The second, and what I want to focus on today, is the idea of how do we implement things well, and the emergence of implementation science. This field aims to bridge the gap between what we know and what we do in healthcare. What is getting in the way of actioning good knowledge? What do we do with all this evidence, and how can we put this evidence into action? To start our journey in this episode, I wanted to better understand the quality problem. So I spoke with Dr. Noah Ivers. He's a family physician at Women's College Hospital, a scientist at Women's College Research Institute, and the Canada Research Chair in Implementation of Evidence-Based Practice. I think this is a no-brainer question, but do we have a problem of quality of care?
I mean, in a word, yes. If a patient comes to me or comes to the next doctor or the doctor after that, the care that they get isn't at all guaranteed to be the same. And we know that intuitively. Like
Right.
we know that some people, talk about their doctor and be like, my doctor's no good. Other people talk about their doctor and say, my doctor's the best. What do we mean when we say that? We mean all sorts of things. One is they really care for me, or I get the sense they don't.
Right.
That's a kind of quality of care. And there's huge variation in that. But also there's variation in like measurable technical quality of care. And this is really important because even if, a given patient might be like, my doctor cared about me and they spent the time with me, or they didn't. But like in the back of their mind, most of the population believes that even if they kind of didn't care that much, they did, they knew what the right thing to do was. There's like an assumption about technical quality of care. And actually all the data, probably like 50 years of data, shows that there's huge variation in the decisions that clinicians make to the detriment of patients. So, this harkens back, like 40, 50 years. If you look at some original research in this space, kids in one postal code, zip code, because it was in the States, would get way more surgeries to remove their tonsils than in the next zip code. Right. And like, that's totally because their surgeon just had a different way of going about their process of care. And that's inappropriate variation. It's an example of variation in quality of care. And that exists not just for removing tonsils, but for everything, for how we manage high blood pressure, for how we measure diabetes, how we manage all sorts of things, how we manage mental health things. So, the care that you get from one doctor to the next is not reliable. And some are higher quality and get better outcomes than others.
So there's quite a bit to unpack because every person hopes and believes that when they go see their doctor, that they're getting the best care.
Yeah.
And you would think that if you put yourself in the other side of that table, that every doctor would think that they are giving the best care. Like, I don't think any doctor walks into a room being like, I'm just going to give horrible care today.
Yeah. No, I mean, nobody's purposefully,
in most cases, right? 99.9%.
Yeah.
So in your work, what are the major drivers of this poor care? Is it inherent in the systems? Is it inherent in the practices? Is it education? Like, what things bubble to the top? I'm sure there's like lots of reasons, but what things feel strongest to you?
Yeah. So first, I want to agree with you. Like, there's no clinician that starts their day, gets out of bed and, cracks their knuckles and is like, I'm going to do some bad care today.
Dr. Grinch, right?
Like there's nobody that, one of the great things about thinking about this problem in the context of healthcare is all of the clinicians are highly motivated. Like they all want to do good by their patients.
Right.
Because otherwise you feel horrible at the end of the day.
Yeah.
And I know that for me, at the end of a day that hasn't gone well, I'm self-reflecting, like I don't sleep well that night.
Mm-hmm.
I feel nauseous. I feel sick to my stomach, So to come back to your question, like why, if everybody's highly motivated, why do we run into quality problems? I think the best answer I have for that is that there's more to do for any given patient than we could possibly do in a given interaction. What I mean by that is, let's take an average patient of mine in family medicine. They're, 50 years old. They need cancer screening. They need their blood pressure managed. Their, child is struggling with mental health. Their older sort of parent is losing their independence, and perhaps also their knee hurts. Okay, that's a lot to cover in 15 minutes. If I'm lucky, I have 15 minutes with them. Yeah. And so inevitably something's got to give. And then somebody like me assessing quality of care, like objectively from the numbers, sees that something gave and says, oh, quality of care wasn't so good. But perhaps this was a purposeful decision of prioritization in that moment, or perhaps it wasn't. But I think the number one thing is like we haven't set up a system that allows us to cover all the things that might need to be covered. And we definitely haven't set up a system where when we measure whether the right things were done, we account for all the things that maybe needed to be done or how things were prioritized.
How much of it is competing demands and competing risks? But how much of it is also just like so much information and knowledge being developed? And how does a doctor keep up with all of that?
Yeah, that's an awesome question. So I want to restate some of the question. Like some of this, as I've said, is there's more to do than we could possibly do. When we say that, we come with the assumption that family docs like me know all the list of possible things I could do to help this patient, but I have to prioritize with the patient in this encounter what makes most sense. But I think if we're talking honestly, there's all these new research findings, there's changes to best practices that come along. And if I'm 25 years into practice, and I'm old, but I'm not that old yet, it's hard to keep up with those changes. And some of the things that you've been doing for 25 years become habit. So I think if we're being honest, some of the ways that clinicians practice aren't like active, rational thinking bit by bit. They're habitual to try to make it simple. And so changing somebody's habit, you and I have both tried to change habits before. Like, I don't know, I bite my nails. You have your own bad habits, I'm sure.
Tons, yes.
Yeah, like changing habits are hard. It's really hard.
It's really hard.
And so if you have ingrained habits of how you like go through your day when you see patients, when a patient says A, you tend to do B, but the new research comes out that says you were meant to do C, like it's hard to catch yourself from doing B and switch to C unless you very purposefully set up a system that stops you. Mm-hmm. So it's like you almost have to outsmart yourself. That's true of any habit changing, right? Like if you want to quit smoking, you better throw out your lighter because the next time you see that lighter, you're going to want to light up. And so in clinic, it's like, if I see a person that's sniffly and for 25 years, I've always prescribed antibiotics. And we have so much evidence now that says I probably shouldn't so readily prescribe antibiotics. Somehow we got to break that like stimulus response habit that exists in my brain. Yeah. And that doesn't get broken just by me saying to you, hey, you shouldn't prescribe so much. Like, just like, if you told me, hey, Noah, biting your nails is not so good. It's not so healthy. Like, yeah, I know. Like the issue is not a lack of knowledge. I've read that study about the antibiotics. It's like, I need help to fix the systems in my mind and in my clinic that have created these like stimulus response relationships.
After chatting with Noah, I wanted to further explore what it means to be an implementation scientist. To learn more about this, I spoke with Dr. Tina Fahim, who's a scientist at Unity Health Toronto. She's an implementation scientist and leads the team for implementation, evaluation, and sustainability at the Knowledge Translation Program at St. Michael's Hospital. So what is implementation science?
So, when thinking about this, there's a number that often comes up, which is 17 years. And so there is a piece of evidence that says it takes on average 17 years for a piece of evidence to be generated to actually be put into practice. Now, I should put a big asterisk next to this that this is potentially a dated number, and there's evidence to show that it could be even longer. But the main point is we're investing all of this time and all of these resources into clinical trials, into generating evidence and generating guidelines, only for that evidence and guidelines to sit on a shelf and not actually make its way into practice and into patient care. And so that's where implementation really comes in, is figuring out what are the roadblocks in this pipeline from generating this evidence to using it in routine practice, and how do we address these barriers to actually get that evidence implemented. So that's the process of implementation. Now, implementation science is studying that process in a scientific way and creating generalizable knowledge about what is more likely to work, what is less likely to work, which strategies might have bigger or smaller effect sizes, and which populations do they work for, with the goal of understanding, again, generalizable knowledge that can be applied to other interventions. And so that process is extremely important, because we don't want to create research waste. At the end of the day, we're doing these trials, we're creating these guidelines to better patient care. But if we stop at that academic output and don't invest the time in implementation, then we're unlikely to achieve the outcomes that we're intending to achieve.
What in your work have you found slows people down? What are the roadblocks here?
There could be quite a number, and it always comes down to kind of which population we're talking about and what the evidence shows. So first of all is kind of the applicability to the population you serve. So if clinicians need to have the buy-in to believe that this drug or this intervention is actually going to be worthwhile to their patients and that the benefits are going to outweigh the harms. And if there's limitations in the population that was studied, or there's resource limitations that's going to prevent them from actually putting it to practice, that could be a significant reason why they might not, choose to adopt the intervention. When we talk to people about what are the roadblocks, the things we hear most commonly are time and resources, right? So there's this misconception that, clinicians are just sitting there refreshing for a systematic review or waiting for the new evidence to come down. But that's not how it works in a busy practice. And there's actually so much information coming at you. And as researchers, we can be a little tunnel vision, like we're focused on the one drug that we've been working on or the one screening intervention that we've been working on. But on the back end, clinicians have tons of this information coming towards them every day. And so for them to kind of prioritize, what am I going to dig into? What am I actually going to implement? And what do I need to make that happen is a very time-consuming process. And they have to prioritize, and they have to decide kind of what they're going to focus on in their own practice, in the order which they'll implement these multiple pieces of evidence.
So, okay, there's so many questions. So say somebody puts together a bunch of evidence, like this could be hundreds of different studies, right? That help put together a guideline. So tons of different studies, hundreds, that help make suggestions about how to best practice, right? For lack of a better term. Is the barrier the trust in the evidence? Like when in your work, is it ever that they don't actually agree with what the evidence is saying or the trust of it? Or is it just like that that was in a clinical trial that's like, and I'm in the real world? Like which of the two seems to be the bigger hurdle, or are they actually both hurdles in your experience?
Yeah, it always kind of depends on what the evidence is and who we're talking to. And when we talk about barriers or roadblocks to putting evidence into practice, we think about it at multiple levels. So there's the individual barriers. There's the reasons why a clinician might not be able to implement the evidence because of time, because of resources, because they're not sure about the quality of the evidence of the recommendation. There's also the individual barriers at the patient level. So maybe the patient doesn't trust in the evidence, or maybe the patient doesn't feel comfortable participating in screening intervention, for example. So there's these barriers that occur at the individual level. Then there's also organizational barriers. So something as simple as physical space. One of my colleagues always talks about a hand washing example, where there was a barrier of getting staff to hand wash before they entered individual rooms. And it wasn't because the staff didn't want to hand wash or they were forgetting to hand wash. It was that the hand washing stations were placed at the very end of the hallway. And for them to make that trip every single time just was not a convenient way for them to actually do the practice. So when we talk about behavior at the individual level, we talk about the need to have the capability to actually enact the behavior change, the opportunity to enact the behavior change, and the motivation to enact the behavior change. And we think about those components of capability, opportunities, and motivation at the provider level, at the patient level, at the policymaker level. And we also talk about barriers at the organizational level and the systems level. So if there's a policy that might be preventing the evidence or might be propelling the evidence, that's also a factor that could be a barrier or facilitator to implementation. And so there's not really a single barrier. It's often a combination of barriers across people, across levels that we have to address. And that's what makes this implementation process complex, because we really have to take the time to do a fulsome assessment of these barriers at different levels and come up with a multi-pronged, multi-level strategy to address the multiple barriers in an efficient and practical way.
How does somebody like you think about a successful implementation? Like, what does success look like in this space? Because it sounds like to me, you're not going to get everybody, like I think when somebody does a trial, you're like, okay, it's funny that you picked hand washing because that's what I talk about in my introduction as the example. But like, to me, someone does a trial and they're like, okay, it shows that everyone should wash their hands. But then in the real world, like it's not happening all the time. So is success just getting everybody, or how does somebody like you think about what is a successful implementation?
Mm-hmm. So I really like this question because I think the ultimate goal is to improve patient outcomes, right? Like the ultimate goal is not essentially in hand washing, it's hand washing to reduce infections and to keep patients safe, right? So ultimately we want to see a change at that level, but and this is where this is where my expertise and kind of passion lies is in evaluation metrics. Often we implement something and then we wait and we expect to see outcomes at this very end. Was there a change in infection rates? Was there change in hand washing? But there's a lot of signals that we can measure along the way that can inform whether our ultimate outcome is going to be successful. We often talk about the importance of assessing our quality of implementation and our process outcomes. And that's really an important investment because those are the initial signals that can tell us if our intervention's ultimately going to work. So for something like hand washing, for example, we might want to assess early on, do people have the intention to hand wash? Are there structural barriers, or are there individual barriers that need to be addressed before we can expect hand washing to take off in this ward, for example? And so we address those things early on. We monitor them early on. We measure things like intention. We assess the context so that if there is an issue, we have time to go in and iteratively intervene. So we haven't spent, a year plus implementing only to not see outcomes at that hand washing level or at the patient outcome level. So I think when we think about success, it also happens in levels. We have to think about success of our implementation quality, success in our process outcomes, and then success in our clinical outcomes. And as implementation scientists, we have a responsibility to also make sure that the way we're trying to get evidence into practice is effective, right? So if I just print a poster and say, you must wash your hands and say, okay, I've implemented the intervention, I've educated people, it's unlikely that I'm going to have a strong implementation quality that's going to lead to strong process and clinical outcomes.
So how do we get people to change? This is a question I posed to Dr. Ivers. How do we help people change? So how do you, because it sounds like some of your work is not just pinpointing where there's bad quality of care, just complaining about it, right? That's what I do. How would you help people break those habits or overcome some of these system constraints and things like that? So what are some ways that we help put this knowledge into action?
So first and foremost, I think most clinicians struggle to accurately self-assess. And I don't blame them for that. They went through their entire training being told they were amazing. That's how they got to that point in their life. And then when they get out there in the real world, they get no feedback at all. So they're still under the mental model of I'm amazing. I'm, here I am. I'm a healthcare professional. And so they're not so good at being turns out I'm not amazing at caring for people with problems A or people who look like B. And I need some upgrading in those areas. We're just not so good at self-assessment. We're human. So step one, I think, is helping open people's eyes that there's a gap between where they would hope to be performing and how they're actually, what the data actually says they're doing. And I think step two is helping them figure out why things are happening that way and not in the way that they would like it to happen. It's sort of a roundabout way of answering your question. Some of the common things we do once they're in agreement, okay, yeah, geez, I'm not doing as well as I thought, is, again, I think, in my opinion, very frequently that's not due to just lack of knowledge. They wanted to do the right thing reliably. Yeah. They might have even thought they were doing the right thing reliably. Now we've shown them they're not, and we can get into the problem solving. And so the problem solving could look like figuring out what cues them in a given situation to do or not do the thing we want to happen. So let's use prescribe antibiotics. It's just such a common, easy one that
it is a
can relate
pharmacy
to, right?
podcast.
Like,
Yeah, it's fine. Yeah,
it's good, right? So patient comes in with a sniffle, and maybe we find out that the clinician really struggles to respond to the patient request in an efficient way. So the patient says, I don't feel well. It's been 5, 10, 15 days that I've not felt well. In the past, you gave me antibiotics. Can I get it again?
Yeah.
And maybe the clinician doesn't have a spiel to lean on in those scenarios that says, yeah, I know it's been 15 days, but there's nothing here that suggests antibiotics are warranted. I think we have to arm them with some sort of alternate behavior, because the current behavior is, with that cue, my response is to prescribe. That's what makes my day easier. And that's the habit that's ingrained in my day. That's how I get through my day. The less I can think,
right,
the easier I get through my day. So if a habit's been working for me, so if we help them identify this cue seems to be responded to with this response, and that response is the one we have to change, let's replace it with something else. And so more so than building knowledge, I want to build skills and create new cues in the environment that help direct their behavior in the desirable way.
If you had an unlimited budget, but you can only do one intervention, one change to the healthcare system to move the dial as much as you can, the Minister of Health's here, I'm gonna blank check, but it can only be one thing. It's like a weird genie. I don't know. It's weird minister genie. I don't know. Anyway,
sounds amazing.
Yeah. What do you think?
We suddenly found oil in Ontario.
Yeah, exactly. And they're but this oil can only fund one thing.
It can only fund one thing.
Yeah. What would it be? What do you think would really move the dial?
I'm going to say goes back to the first thing we were talking about. Every person in the jurisdiction has, I'm going to cheat a little bit because it's like a mixed thing, multifaceted.
There's no rules to this, really.
Every person has a primary care clinician who is supported by a team, who is supported by a digital health infrastructure. Yeah, wouldn't that be cool, right? Then the information can flow horizontally and vertically. I think the other thing we didn't talk about that this would enable more,
right,
is the idea of building, not to burden the patient, but to build their capacity when and if they're ready for, self-management, to empower them to ask the right questions if something's forgotten, to empower them to, solve some of their, day-to-day issues without leaning on the clinician that is, already overburdened.
Yeah.
And we didn't really talk about shared decision, initiatives that can help implement shared decision-making, but we have really good evidence that when that's done in the context of, a person with sniffles, it really helps to reduce inappropriate antibiotic prescribing.
Yeah. But it takes more time.
And it takes more time.
Dr. Ivers' points about how to better incorporate patients into shared decision-making really struck me. I wanted to further explore how we can incorporate patients into this kind of work. To do so, I talked with Dr. Fahim about how she does that in her work. Maybe you could talk a little bit about where engaging with patients fits in, because I think we've spent a lot of time this morning talking about clinicians because we want to convince them of change. But how does engaging patients fit into the kind of work you do, and how does it shape it?
I think patient engagement, I think it's something that's becoming much more focused on in research, and we're understanding the importance of engaging patients really early on in the research process and in the research pipeline. So for example, using something like guidelines, typically we didn't used to engage patients until the end of the process when it was time to have a screening intervention. We asked them, what are some of your concerns around screening? But what we're finding early on is if we engage patients right at the level of even conducting the systematic review, conducting the trial, they can provide insights on, are we even looking at the right outcomes? Are we measuring outcomes that are going to be important to patients? Or are we only thinking about clinical outcomes that clinicians and researchers find important, but might be less important to patients? So, we often talk about comorbidities and illness and death, but things like quality of life or ability to engage in activities, those are important outcomes to patients. And if those are not found in the review, then we're going to, spend all this time conducting a review, creating guidelines, and still not necessarily addressing some of the patient concerns. So I think there's this shift in thinking in the research pipeline that patients don't need to just be involved in the last step when we're ready to implement and we've packaged the evidence. They should be involved very early on, from grant generation, from idea generation, from defining outcomes, collecting evidence, all the way through. So when I think about my role as an implementation scientist, that's definitely the approach we take, is making sure that, just at that grant phase, at the planning phase, that we're engaging with people at multiple levels, engaging with patients, identifying their needs and priorities, and working with them to answer questions that are relevant to them and to develop interventions that make sense for them. So that's kind of the first piece. And then the second piece is thinking about, once the evidence actually reaches a primary care practice, well, what do we need to do to support clinicians to engage with patients to make decisions? And so we hear a lot more about shared decision making. And going back to the example I used earlier around screening, that's something we hear, often is, the recommendation is not to screen, but the patient wants to be screened. So a lot of the time physicians say, okay, well, I'm just going to do this test because my patient is asking for it, because they don't have the tools and the resources to actually have a conversation with patients, to discuss benefits and harms, to explain the evidence, how the recommendations were created, so that a shared decision-making process can occur. And so I think that's what we're seeing more of, is that in addition to creating this piece of evidence and this guidance, we need to be creating the tools that's going to facilitate implementing it into practice, facilitating shared decision-making, answering questions, fostering trust in that clinician-patient relationship.
We are really good at producing evidence. We're really good at figuring out what works and what doesn't. We're not very good at making it part of a day-to-day practice. That final mile, the leap from evidence to action. What we learned today on this episode is that we need to account for humans, human behaviors, human incentives. We also need to account for systems, both its flaws and its structures. And all of this is no easy task. We need to produce health systems that are able to learn, adapt, and slowly change. One thing that really struck me, even before this episode, was a Noah Iverism, I call it. He would always say, guidelines don't implement themselves. And it always kind of struck me that all the evidence that goes into building a clinical guideline or producing all that is not the most important part, but actually, how do we action it? How do we put that evidence into action? This episode of the I'm Pharmacy podcast was produced by Steve Southon, Kate Richards, and me, Mina Tadros. Musical accompaniment was from Steve Southon and Diego Martinez. This episode was edited by Steve Southon. Special thanks to Dr. Noah Ivers and Dr. Tina Fahim. We'll be dropping new episodes every single month, so make sure to subscribe wherever you listen to your podcasts. Stay safe and keep asking questions. Catch you at the next episode.